So this is again another important message that it was initially put there by Bastian Bloom, which is quite simple in words, but it can be quite difficult in real life. In words, we can say that anytime we see a patient, for whatever reason, not just gait disorders, but anytime we see a neurological patient and other diseases, what you see is the net result of the problem plus what the patient is trying to do to compensate for additional issues or for that particular problem. So it's always there's always a mix between these two domains that we should be keeping into account. Going back to the example I made before, white-based is actually not the primary problem. The primary problem of gait disorders in cerebellar disorders is imbalance. And white-based, which is used to define gait disorders and cerebellar disorders, is a compensation for the mediolateral instability that this patient have. And this is actually the reason why tandem gait is very specific, because with tandem gait, you challenge this even more. So as you can see, in this particular example, we define the problem with the compensation, actually. And if you were to touch the patient and to hold their hands while he or she is walking, you will see that the base of support will narrow, again, showing that this is a compensation. Another example of compensation is what you see in antalgic gait, which is typically an asymmetric limping slow pace gait. And this is typically seen in orthopedic problems like hip pain or knee pain. And in that particular case, the patient is walking slower or with more instability, not because of the problem itself, but just because the patient is compensating for the pain that each step is causing. And again, if you were to give them a painkiller, obviously a strong one, you will see the gait becomes normal all of a sudden. So the major problems that the body is trying to compensate for are imbalance, first and foremost, pain, and this is another important one, and in some cases also weakness. Typical example in case of weakness is what you see in people with stroke when they have a hemiparesis and they have a large circumduction of the leg. Not because that's typical of stroke. And again, textbooks will say that this type of gait is typical of stroke patient. No, they're just compensating for the weakness of that leg, and mechanically it makes more sense to have this large circumduction instead of trying to move forward. So these are just a few examples, but there are many more. And sometimes in clinical practice, it's quite difficult to differentiate one from the other.